Hello everyone. As part of our Better Outcomes webinar series, I'd like to thank you for joining us online today for this very special live broadcast. My name is Emily Eberly with SAXE Healthcare Communications, and I'm your technical producer. It is my pleasure today to welcome you to our webinar, Alternatives to Intubation for the Older Patient in the Emergency Department. And now, I'd like to introduce you to Andrew Dunnan, who is our moderator today. Andrew is a staff nurse at Brigham and Women's Hospital Emergency Department in Boston, Massachusetts. He is responsible for patient treatment and care in a Level 1 trauma, designated stroke, cardiac, and hematology oncology center. He serves as the Emergency Service Assistant Orientation Educator. Andrew has been very active in patient and family-centered care, and in 2012, he was the founding member of the Brigham and Women's Hospital Emergency Department Patient and Family Advisory Council. Andrew, welcome, and I'm so glad to be working with you for this special session. And we thank you for all of your support in moderating this important webinar for so many people today. Are you ready to get started?
I am, Emily. Hello, everyone, and thank you for that very kind introduction. The title of today's webinar, as mentioned, is Alternatives to Intubation for the Older Patient in the Emergency Department. Speaking today on this very timely topic is a leading expert and colleague, Dr. Kei Ouchi. Dr. Ouchi is currently an emergency medicine and home hospital attending physician for Brigham and Women's Hospital and an assistant professor of emergency medicine at Harvard Medical School in Boston, Massachusetts. He is the lead early-stage investigator on aging researchers in early stages areas and founder of the Boston Emergency Medicine, Palliative Care, and Aging Research Consortium. Dr. Ouchi is active in several medical associations, including the American College of Emergency Medicine and the American Geriatric Society. He has published and lectured extensively on the relationship of emergency medicine and palliative care in the older patient. Our speaker today discloses no conflicts of interest associated with this presentation. And please note, this educational activity is approved for 1 contact hour for nurses and respiratory therapists, accreditation statement as listed below. Support for this educational activity is provided by Philips. It is now my pleasure to turn the presentation over to Dr. Kei Ouchi. Are you ready to get started?
Yes, thank you for the kind introduction, Andrew. And thank you everyone for being here. And today the title of my talk is Alternatives to Intubation for Older Patients with Serious Illness in the Emergency Department. And this is a passionate topic of mine. First of all, I'd like to review the learning objectives for today. Our first objective is to discuss the significance of emergency department visits for older patients with serious illness. And I'll explain what that means and what that means for the patients mostly. We will also discuss the use of non-invasive ventilation as an alternative to intubation for these critically ill patients. And I'd like to spend much of my time trying to describe what the best practice approach to crisis communication is in emergency department. And I will go through exactly what I mean by that. So to give you a perspective, why am I interested in this topic? So I met this gentleman named Frank. He was a patient of mine when I was in training. He was 69 years old with metastatic cancer presenting to the emergency department with fever and back pain. What was striking about him was that this was his 6th emergency department visit in the last 6 months. Every time he got admitted or discharged, but he kept on coming back. What we realized after speaking to him and his daughter was the fact that he knew that he was dying, but he just didn't have a way to control his pain at home. And this was never discussed with anybody, and he didn't know where to go, so that's why he came to the emergency department. So after that conversation, he went to home hospice from the emergency department and died peacefully at home a few months later. His daughter Andrea, depicted on the left, came to talk to us and said how important this conversation was for her dad in the emergency department. This sort of started to make me think, how many more people needed this conversation before this time? When you look in the literature, Most Americans visit the emergency department in the last 6 months of life. If you look at this picture with function and time, the time in which patients are starting to decline is the time when they present to the emergency department, one reason or another. And most patients don't die that day, like patients depicted on the red line. And actually, most patients with serious life-limiting illness have a chance to recover from that particular moment and continue to have that type of decline until death. So emergency department visit is an inflection point for a teachable moment for these seriously ill patients. This is what I mean by the significance of emergency department visits. So disease-based literature is clear. For example, for congestive heart failure patients, 1-year mortality after an acute heart failure exacerbation ED visit is well depicted. Depending on the age, the percentage of people who die within 1 year is well known. And these numbers are striking, not really focus of emergency medicine training, and also true in other disease groups. So I'd like to spend a little more time talking about what crisis communication is in emergency department. There are a few types of goals of care conversations that can happen in emergency departments, and I will use this picture to try to explain that. So if the time is going from left to right, and this is the time of someone's diagnosis of serious illness, such as lung cancer, and that's the time when someone dies, the type of care should change ideally over time as someone approaches death. And the clinical settings do change, unfortunately, too, as the disease progresses. Advanced care planning is typically the conversation that you would have with an outpatient clinician before you have a serious diagnosis to think about what's ahead. A lot of times, this is too early for patients to think about what would happen if they get sicker. I coined a term called serious illness conversation when patients are diagnosed with serious illness and getting sicker. And this is actually the emergency department visit where the goals of care discussion is really a teachable moment for patients and also for clinicians. I will talk more today about the crisis communication, which is a conversation that needs to happen much later towards death. And very often, this is too late to have a really well-informed conversation about what's important to the patient, and your hands are tied because of the time limitation. My research focuses on this serious illness conversation, but today I think more relevant to more clinicians here on this audience that I will talk more about the crisis communication. So the difference between crisis communication and serious illness conversation is that with serious illness conversation, the patients are typically clinically stable, and the discussion is around values and preferences of patients, and no decision-making is particularly necessary at that time. However, during crisis communication, patients are often unstable, and we will try as much as we can to discuss values and preferences of patients to align their care to their goals. And unfortunately, urgent decision-making is necessary at that time. So I'm going to spend the rest of my time trying to explain what I think is the best practice approach to crisis communication in emergency department. So let me go through this. I remember seeing this type of patient in emergency department recently. He was a gentleman in his 80s with metastatic lung cancer, and he was obtundant. And the son or the family member goes, "Put him on the breathing machine." I'm not sure anyone in the audience where clinicians had this experience before, but this is actually a common occurrence in emergency department. And when this happens, I know that there is going to be a communication difficulty, and I need to figure this out. What goes through my mind is that this is a worldwide survey that was done by economists. Why does son not understand that this is a really difficult problem right now. Because if you survey most patients think that living as long as possible is not really a primary concern. And what's most important to them is to not be a burden financially to their family or be comfortable without pain. Additionally, the conversations regarding what's important and how they would like to be cared for towards the end of life, this is really not common in all countries. In the United States, only 57% of patients report this type of conversations. In other countries, even less. And when you ask patients and families what they would want if they were approaching end of life, and most people would say that they would like to die at home. That's what we would all picture, surrounded by family and being comfortable. However, in reality, only 30% of patients die at home in the United States, and this is less so in some other countries as well. And if you think about emergency department intubation itself, that procedure, it's particularly significant for older adults because this is not the same for young patients who get hit by a car and needs an intubation. For older adults, especially with those with serious illness, there's an associated inpatient mortality with every intubation. And as you can see on this picture, older you get, the chances of you dying in a hospital increases. And strikingly, even if you survive, the chance of you returning home is diminishingly low. More importantly to older patients, this study depicts the functional ability of older adults after ICU stay, and every patient who gets intubated goes to the intensive care unit. So what this study showed was that they followed a few hundred patients before they get ill, and they measure their physical ability before they get ill to go into the ICU and after they recovered from that illness. And the left-hand column shows pre-ICU functional trajectory, what kind of physical disability they had. And the right columns describe what their functional trajectory is after the ICU stay. So if you look through this, patients with mild disability, they have only 49% chance of retaining that mild disability, minimal disability, after the ICU stay. And they have the same, they have a 27% chance of developing mild to moderate disability after the ICU stay, and severe disability, 13%. And death is depicted on all the way at the right. So if you think about our patient that I just talked to you about, that patient at baseline was really only able to walk a few steps and gets hypoxic very easily. There's a really, really good chance that even if he survives, his functional disability will even worsen. And this is a critical question for older patients with serious illness. Will the patient be willing to live for that function if they get worse after the critical illness? And I feel like we don't really do a good job explaining to patients or the caregivers this plain old fact. And do they really understand this, is my question when he asked me, will you please intubate him? So there are ways in which you can lead this conversation in a patient-centered manner that's respectful. This picture depicts my mentor, Susan Block, teaching other clinicians about how to lead this very difficult conversation. This conversation, as you can imagine, if you've ever been in a clinical situation like this, is very difficult because patients are often in acute distress and they're also in emotional distress where decision-making is really difficult. But what we're trying to tell you today is that there are evidence-based ways in which you can lead this conversation so that patients can get to decision-making as well as possible in that given situation. So best practices to lead this difficult serious illness or crisis communication exist. For example, Serious Illness Conversation Guide was developed at Ariadne Labs in Boston, where my mentor Susan Block had tested this conversation guide. This is a checklist of items that clinicians can go through with patients or caregivers to better understand what their really priorities are. And this was developed for outpatient clinics, and it has undergone clinical trials here at Dana-Farber Cancer Center to show that it can decrease anxiety, depression, and also lead to earlier, better, and more conversations in outpatient settings. There are other best practices such as Vital Talk. This is an organization that teaches communication skills to clinicians, and there are specific steps in order for a clinician to discuss end-of-life care goals. And they include specific phrases and specific ways to respond to patients' emotions. Now, this has also shown to improve clinician communication skills if you videotape them later on. And it has also been under clinical trial in larger studies recently to show improvement in the alignment of care in critical illness. There are also other best practices, such as best case, worst case, that's developed in Wisconsin to lead to decision-making for surgical options for serious illness patients, depicting what could potentially be the best case scenario for treatment 1 and what's the best case scenario for treatment 2, and where most likely the patient lies in this probability scheme. This has also shown to improve comfort level of clinicians in surgical setting to lead this conversation. Now, all these best practices do exist. They do work to improve the communication skills and lead to better decision making. However, what's the best way to do this in emergency department is very unclear. It's a very difficult environment to study this in, and the fact that patients are coming in at random makes it even harder for someone to standardize this conversation. So today I'd like to spend the rest of my time describing what I think is the best practice for crisis communication. And here are the steps, and I will go through each one of them. One, first of all, as a leading clinician, you have to prep your team so that they understand what conversation you are leading right now. And then with patients or caregivers, building a trusting relationship first is the most important aspect of this conversation. And describe the medical situation, kinds of decisions that need to be made, and its urgency is the next step. And fourth, this is when we can try to explore the values and preferences of patients so that we can better understand them to match the care to the values and preferences of patients. And then as a clinician, we would summarize with reflective listening so that they feel like they've heard us. And finally, as with any other medical intervention or treatment, as clinicians, we make recommendations to patients or caregivers about what might be the most goal-concordant care in this particular situation. So I will go through each step now. So step 1, to prep your team, and this includes prepping your nurses, potentially involving social workers if you had them, to alert them to this hyperacute situation, and let everyone know that there is a critically ill patient here, and a clinical team will do all non-invasive means to make sure that patients stable as much as possible and be as comfortable as possible, while I, the clinician, go have this decision-making conversation with the patient or caregivers. So I make sure to let them know that they are able to do all non-invasive means while I have this conversation. And this is when I think the next step of non-invasive ventilation could be helpful. When, in my experience, if you call a respiratory therapist to bring a BiPAP for this particular patient, he or she may ask me about contraindications. And I clearly understand the relative contraindication of starting non-invasive ventilation for patients in this particular situation because of aspiration risks. However, in order to treat his dyspnea and potentially hypoxia, just temporarily while I try to figure out the goals of care, this could be a great adjunct to buy me some time. And during the same time, I'm tempted to give medications like morphine, small dose of morphine, or midazolam to titrate to affect the IV push to control the patient's dyspnea. And this can be titrated to effect. Now, you might think, and this is not a traditional teaching of emergency medicine, that non-invasive ventilation is contraindicated in these situations. But what I would say after reviewing the literature is that there's really not enough evidence, but it's really not always fatal. So if you look through all these recent studies, and they're all observational studies, and they're all just basically case series of older patients who are DNI and were placed on non-invasive ventilation for either treatment of whatever the disease process is or a comfort in different countries, mostly in Europe. And as you can see, the in-hospital mortality is high, but it's not 100%. So the fact is, there's really no great evidence to not use non-invasive ventilation, and potentially it could help patients' symptoms while you're definitely trying to figure out the goals of care, and potentially as a definitive destination therapy for this particular illness. So I think this is an under-researched area and more to be done in this area in the future. So going back to the crisis communication steps, step 2 is to build a trusting relationship with patients or surrogate. And what I mean by that is, if possible, we try to obtain information and perspectives from medical records or patient's outpatient clinician, if possible, or from the patients or surrogate. And we can say things like, we've reviewed the chart and spoken to Dr. Johnson about his situation. And then up front, it's really important to acknowledge the stressful and difficult situation, because this is probably one of the hardest times in their lives, and you want to acknowledge that up front. I can see that he's in a difficult situation, and describe the immediate aims of the treatment. So you can say things like, we will give him medications to ease his shortness of breath, so we have little time to figure out what to do next. And emphasize patient strength. I can see that he has gotten through several tough episodes like this in the past. And this is one of the key things that you want to do to establish a trusting relationship with patients or surrogates. And in step 3, we will describe the medical situation, kinds of decisions, and its urgency by first asking for permission. Would it be okay if I shared what I understand about this situation? You could never ask enough permissions in these conversations because it gives patients or surrogates a sense of control over this conversation. And you can communicate your hope. I hope that we can turn this situation around, but I'm worried that his cancer or heart failure is worsening in spite of all the treatments because he has been in hospital twice in the last 6 weeks. And he's very sick now. I wish we had more time to figure out how to go through this, but we need to decide very quickly what kind of treatment he would want in these circumstances. So using the words like hope, worry, and wish will really align our intentions, which is really true. We would like to help the patient as much as possible to the patients or caregivers. And this will help establish that relationship as you also communicate these needs. And step 4, this is to explore patients' values and preferences. Now, this is never taught to me when I was in emergency medicine training, but it's so important to figure out exactly what the patients may want in this particular situation. Just like obtaining history and key history points to decide your medical decision making. So you can ask questions like, as he found himself getting sicker, what are his most important goals? Or, how much was he willing to go through for possibility of gaining more time? Now, these questions, there are a series of questions like this to figure out patients' values and preferences. And these are really up to that patient or caregiver's sort of state of mind. And then so the clinician has to sort of use your clinical judgment to figure out which questions might be the most appropriate one for caregivers in front of you. Next, the step 5 is to summarize with reflective listening. So what this step allows is that we are communicating what we learned to make sure that we got it right, and also to make sure that they know that we've heard what they've said. So you can say things like, what I heard you say is that his most important goals are, whatever it is, to be independent or not be burdened to his family. And I also heard you say that he'll be willing to go through maybe one more trial of intubation or maybe not, but not machines. Does that sound right? And this is where whatever you heard from the patient or caregiver may help to put this conversation into context. Now, the last step is to make a recommendation based on patient's values and preferences and suggest a medical option. Now, for this particular patient, based on what you told me, I would recommend that we treat him intensely with medications and oxygen to see if we can turn this situation around for now. We will have a breathing mask called BiPAP that we could also use if we need to, but we won't put him on the breathing machine because he hates being dependent on other people should he ever not be able to come off. We can reevaluate how it's going and whether you want to consider other options later. So you can make a recommendation like that based on the known statistics that you know in your head about older adults with serious illness and intubation and patients' values and preferences as a clinician. Now, I'm going to go back to what the patient's son said initially. So he said, why can't you put my dad on the breathing machine? And he was angry and slightly tearful. And what he really meant is that the wrong thing to do here is to give a cognitive response, which is to reiterate the known statistics. Well, the patient is 89 years old and he has stage 4 lung cancer with pleural effusions. And in this situation, the chance of him surviving is likely less than 5%. And if he survived, he would never go home to achieve that, whatever the functional status that he wanted to achieve. So that's actually the wrong response, and that's called a cognitive response to the emotional statement. Actually, this why can't you put my dad on the breathing machine is an emotional statement. And for emotional statement, we would recommend an emotional response such as the acronym NURSE, which can be found on Vital Talk website, but naming or understanding or respecting the emotion. So basically, to translate that statement, what he was really saying was he looks short of breath. Help him is what he was saying. And he is not looking for the statistics that you may have in your head. So to be honest, this type of scheme of crisis communication can work sometimes, and sometimes it does not. And ultimately, as clinicians, we're here to make recommendations based on all the facts that we can gather clinically and try to insert a medical judgment so that we can help patients get the care that would be aligned to their goals. Now, this may not work sometimes, but it's up on us to practice the best way possible. Additional resources for something like this can be found in Ariadne Labs, where they've developed the conversation guide checklist. Many other education and training opportunities are available at the Center of Palliative Care at Harvard Medical School, as well as Vital Talk, the nonprofit organization. And a lot of ways in which to care for these patients with serious illness, to control their symptoms, or to lead this kind of conversation can also be found in Palliative Care Network of Wisconsin, where they have extensive library of evidence-based approaches to dealing with symptoms and communications in palliative care settings. So to review, the take-home points for today are that emergency department visits are signs of precipitous clinical decline for patients with serious illness, especially when they're older. Both serious illness conversations and crisis communications can be improved in emergency department, and it's on us to try to spread the best practice possible. Crisis communication skills can be acquired to deliver care aligned to patients' goals and values. And just like any other skills in clinical practice, this is learned practice to perfect it. I just want to take a moment to acknowledge my mentors who's been supporting this work. So Dr. Susan Block is a professor of medicine and psychiatry at Harvard Medical School, and she was the primary mentor who put me in this field to try to make a difference in emergency medicine. And recently, I've been working more with Dr. James Tulsky, who is also the professor of medicine at Harvard Medical School and now the current chair of psychosocial oncology and palliative care at Dana-Farber Cancer Institute. So we have been working together a lot on how to build scientific evidence regarding these communication skills. So at this time, I'd like to turn over the presentation to Andrew to see if there are any questions that we can entertain or have more discussions regarding this topic. Andrew?
Thank you, Dr. Ouchi. We would like to mention at this time, again, this educational activity is approved for 1 contact hour. So to obtain CE credits, go to saxetesting.com/BO. You'll need to register at the site, complete the evaluation, and upon successful completion, you will be able to print your certificate of completion. Support for this educational activity is provided by Philips. So at this point, we'd like to now open the presentation up to questions from the listening audience. One of the first questions that's come to you, Dr. Oichi, is from James. His question is specific to the use of non-invasive ventilation. Is there an optimal pressure to start a patient at when placed on non-invasive bi-level therapy? Is it based on height, weight, or potentially crisis level?
Great. Thank you, James, for that question. And there is no evidence-based way to come up with the optimal pressure for non-invasive ventilation. However, most clinicians are comfortable starting at 10/5 and titrate to effect. And I think that's a really comfortable place to start for many different conditions, including this one. Thank you.
So we have a question from Dawn. Dawn asks how she might go about getting a copy of the Serious Illness Conversation Guide. Is there some place that our audience can go to get access to this guide?
Yes, Dawn, thank you for that question. So the Serious Illness Conversation Guide is available online at Ariadne Labs website, and I'm sure you can simply Google Ariadne Labs and Serious Illness Care Program. That's the program that created that, and it's also found on PubMed if you search randomized control trials for the conversation guide. But I think most easily on the Ariadne website.
Great. We have a question here from Gail, which I'm sure many of our listening audience are thinking about. What about situations where the family and the patient are actually at total opposite sides of the spectrum in terms of their ideals for care, or family members that are actually at odds with one another over how to proceed? How have you handled situations like that?
This is a very, very important question, and this is a question that we all struggle with. Now, I didn't include a slide in here, but this is called, one big reason why this happens is because of prognostic awareness. So there are patients who are seriously ill and terminally ill, and they haven't, because they're anxious or scared or one reason or another, they haven't grasped the situation of how ill they are. And this is called the prognostic awareness. And basically, it's a really extreme situation when stage 4 lung cancer patient says, what do you mean? I don't have cancer. Like that doesn't often happen, but very often patients really underscore their disease severity sometimes. And this has been well documented in literature that patients actually don't hear the serious news when doctors actually disclose that news in an outpatient setting. Now, our job in this critical situation in emergency department before an imminent decision making is that our job is basically to control their emotion so that we can try to advance their prognostic awareness if that's the reason why they cannot get to a decision making. So the communication here is not really just about informed decision making, about the probabilities and things like that, staging of the cancer. It's really not much to do with that. Mostly it's about controlling the emotion and managing them, even if you can't control them, so that you can help them see how sick they are. So we can get to the decision-making part next. So this is a very important question that Gail pointed out regarding how to tell patients when they don't know how sick they are, and another about how to manage the conflicting opinions of caregivers or families in the room regarding goals of care. It's well documented that these conversations do need to happen repeatedly, and anxiety or how scared they are may inhibit them from really taking in that information. So when we see these patients in emergency department, it's very common that patients with serious illness have low prognostic awareness or lower than expected. And our job in crisis communication is to try to close that gap as much as possible by attempting to manage their emotions. So what I mean by that is they are not going to hear you if you try to explain that this is a stage 4 lung cancer and lung cancer stage 4 is not curable. What we would need to do in communication like this is to try to help them see how sick they are by asking them to talk about what their life is like. And this is allowing opportunities for patients or caregivers to describe that to you, to release that emotion so that you can get to decision making. So that's the core purpose of crisis communication. And it's not about informed decision making or shared decision making using statistics at this time. And in regards to conflicting opinions among family members, what I would say is that this does happen, and sometimes it's not controllable, but as clinicians in these emergent situations, we are asked to control that situation, and the first step is, again, to manage that emotion so that people can get to the decision-making part. And if you could just try doing that once by trying some of these phrases or using some of these best practices, I would encourage you to try them so that you can see what that difference might bring. Like I said, not everything is fixable sometimes, but we have to achieve for what we can do in the given situation. Thank you for that question, Gail.
Thank you, Dr. Uchi. We have an interesting question here from Trevor. I know from being a colleague of yours and working with you that you've done a bit of work with other providers in developing a process to have the serious illness conversations and the crisis communications. So I think this question relates to a lot of the stuff that you've done in our department. Do you find when discussing the patient condition and wishes that being on the same eye level with patients or family members is a key component to ensure the patient and family is in control of questions and treatment of their care, and also to ensure trust?
Yes, thank you for that question. And this is, I'm not sure how many people in the audience are palliative care clinicians, but this is probably one of the first things we all learned in medical school or nursing school, and often quickly forget through our clinical training. But what's important, yes, the answer is simply yes. Being on the same eye level, asking permission to see if you can initiate the conversation, inviting them to speak on what their perspectives are. These are all really common basic primary palliative care communication skills that we teach to our trainees and also to our colleagues at our institution. And they do that in those organizations that I had mentioned, like Ariadne Labs, Center for Palliative Care at Harvard Medical School, Vital Talk. All those organizations do that. But they're just simple primary palliative care skills that we all need to sort of relearn and practice in our practice daily to get good at. And yes, these are the components in which will allow you to really foster that trusting relationship in a very short amount of time in emergency department. So I would encourage everyone to try to, try to go to some of these trainings and see if that will really make a difference in your clinical practice. Thank you.
We do have a question here from Susan, who is a pre-hospital provider, and I think it's apropos as one of my takeaways from working with you is that, and also the composition of our listening audience being nurses and respiratory therapists primarily, is that this really is an interprofessional issue that needs to be dealt with. So Susan asks, as a pre-hospital provider, what can you do to encourage these conversations? As a pre-hospital provider, they often deal with the families and patients on an ongoing basis as they decline. I'm assuming basically often going to calls and getting to know patients and family members, going to repeated calls to take them to the emergency department. So do you have any advice for our pre-hospital provider colleagues?
Thank you, Susan, for that question. I think that in this particular topic of training and communication skills in palliative care, pre-hospital providers are often not involved. And this, as an emergency medicine trainee, I was in those ambulance rides with you guys and witnessed those situations firsthand. This is actually the first time when patients or caregivers may have to have this decision-making, or whether to go to hospital or not even, must be sort of discussed at home or on streets when you guys first encounter the patients when you get these calls. And as far as I know, there is no specific standards of training for this particular situation, rather than basically, standard language for leaving against medical advice type of language. And yes, the informed decision-making, again, in this discussion is important, but more importantly, especially for patients with serious life-limiting illness, I think, Susan, you're exactly right that this conversation about how to lead this conversation about whether to take the patient to the hospital or not is really important, and we should try to emphasize the training for pre-hospital providers as well. Thank you.
Great. We have another question that unfortunately, not unfortunately, but deals with legal issues, which we all know as clinicians come into our lives. The question is from Raphael: how would you deal with a situation where the caregiver who's at the bedside with the patient does not actually have the legal power of attorney? For example, would be that the sibling who has the power of attorney is out of town, and does that present challenges to this conversation, and can this conversation actually be held telephonically with family members that are remote?
Great question. Thank you, Raphael, for that question. So this is on back of all of our minds in emergency medicine, Andrew, myself, everyone, when this conversation is going on. And well, the actual state-to-state law in regards to who sort of trumps the decision-making when patients lose capacity is different depending on the state. And it really depends on the state where the MOLST form, the medical order for life-sustaining treatment form, would trump other caregivers or family or surrogates in the room. It really differs between states to states. And in Massachusetts, even if a patient has completed MOLST form that says DNR, the surrogate who is in the room can overcome that, and that's legal. Now, what's legal is different from what's ethical in our clinical practice. And we have to keep in mind that what's ethical is not going to be trumped by the legal issues usually. So we are tasked to provide the best care that's aligned to the patient's goals as much as possible. And in given situation, in using all the information that you can possibly use, your decision as a clinician was to intubate the patient because there was so much uncertainty, or withhold the intubation and try non-invasive ventilation because of all the evidence that you have gathered. I think you're still acting in the best interest of the patient, and that's really what's honored. We are never required to provide care that we think is going to be futile to the patient, regardless of what surrogates may say. And in reality, when push comes to shove, there are situations where I would make a recommendation saying intubation is really not indicated. And surgeons do this very well. When they are faced with emergency surgery, they won't even offer that option when they know that that's not going to help the patient. And there could be a conflict between the surrogate and the clinician about whether to intubate someone or not. That happens sometimes in emergency department. And actually, what most clinicians do is we are encouraged to make that recommendation. And if the patients or surrogates don't take that recommendation, that's just the way it is. And we sometimes do intubate these patients. But I don't think we're legally obliged to make or do treatments that we believe professionally will not benefit the patient.
I found it interesting, and I am going to interject my own question here because of our work together, but you did mention that during your medical training that there was really no time spent having conversations about the patient value conversations that you're now focusing on with your work. And I know that you worked directly with our patient and family advisors in our department to explore these conversations with the input of patients and family members. Was there anything surprising or extremely enlightening that you learned as you talked to patients and families about what they wanted out of these conversations?
Mm-hmm. Yes, many actually. We learn a lot about how to have these conversations from patients or caregivers or families. And actually, the conversation guide from Ariadne Lab, it all of those or other tools, all of those are patient-tested languages. So patients and caregivers were extensively involved in crafting those language to make sure that like the doctor doesn't sound arrogant or disrespectful. And those are reviewed repeatedly by patients and caregivers. And that's why they're written the way they're written. And yes, even if you use those evidence-based guide, sometimes we still learn new things from our patients again and again, just like we do in clinical practice. And yes, for example, in emergency department with patient family advisory council members in emergency department, we learned that these conversations that I try to have with patients, it's really important to involve their caregivers during this conversation if they're present, or it's really important that patients want us to communicate our findings to outpatient clinicians. And these are things that was not originally on my radar, but things that we learn from patient family advisory council. And those are vital to what makes these conversations as good as possible.
A question here is, given that less than 50% of patients in the Economist study have advanced medical directives, so we're talking more than just ventilation issues, but all of the medical interventions you might clarify in your advanced medical directives. How many of your patients do you see that aren't coming in with any kind of advanced medical directives, who seem to have strong preferences against receiving invasive medical ventilation?
I see. So I think the most current systematic review shows that up to 98% of patients who come to the emergency department don't have advanced directives that's written. Further, and the systematic review ranges from like 50 or so percent to 98% on all the literature that's out there right now. Further, most advanced directives are misunderstood by healthcare professionals, including pre-hospital professionals, physicians, nurses, and that's well documented as well in the literature. So it's really difficult to say how that's going to, the situation right now is that you can almost assume that there's really nothing documented, and things are changing with the use of electronic MOLST forms in New York State and different places and things like that. But I think that we are still struggling as emergency department clinicians to have more documentations or better understanding of the patient's wishes in emergent situations.
Mm-hmm. So to field a few more questions, in particular about some of the specifics with BiPAP, how have you found, how long do you feel that you put a patient on BiPAP before you start to consider whether you need to have a discussion about intubation with the family? Do you find that there's a point where you realize that non-invasive ventilation is turning out to not be an effective way to support the patient and their wishes?
Mm-hmm. Thank you. So in clinical practice, in my clinical practice at least, so I'm talking about patients with serious life-limiting illness or older adults and non-trauma cases. The use of BiPAP or non-invasive ventilation actually for like an acute illness like a pneumonia or CHF exacerbation or COPD exacerbation, this could go on for hours, if not days, when you think the patient should be intubated. And I think those people in the audience who may be palliative care clinicians may speak to this much more strongly than I can, but you know, that most people's clinical experience, these people live for a long time, certainly not minutes. And but the decision point to have this discussion about whether to continue this treatment or move on to intubation or no intubation should happen when you're making this decision about putting someone on non-invasive ventilation for older adults with serious illness, because you're basically buying time to come up with this decision making, and that would be the best time to do so. if the situation allows for a revisit to that conversation while the patient remains on non-invasive ventilation, that's a gift, and you can try to progress that conversation further after a test of time. But what I would say is that in general, in non-traumatic illness patients, non-invasive ventilation in my clinical practice can last for hours to days, and even if they end up dying. And you would know immediately if it's actually helping patients or not. Because if they're not breathing, then it's not going to work. So thank you.
Question about the reception of these conversations with colleagues. How are you finding that other emergency medicine attendings are responding to your work? Is this something that they can see themselves doing, or do you feel any pushback from the discipline at all?
Great, thank you for that question. So there has been few publications regarding how emergency physicians feel about these conversations and how we feel the urge to improve this issue in emergency department. And American College of Emergency Physicians has put out a statement in Choosing Wisely campaign that's kind of started by American Board of Internal Medicine, that consultant palliative care and having these conversations earlier is really what we would push as a professional society for all emergency physicians. So we certainly do feel the need to improve this conversation skills, and this situation certainly needs to be improved as a professional society. I think that the work is still at its infancy, where clinician communication trainings, we're doing them at national conferences, but not as predominantly as we hope. And I think it's only a matter of time when this is starting to catch on as we grow dual board certified physicians in emergency medicine and palliative care to probably around like 150 around the country right now. I think the number is growing, and things are changing. I would say my vision is that in a few decades, people will look back to this and say, emergency department clinicians used to intubate these patients for what particular purpose? And I think people will have a different perspective, but time will tell what would happen.
Great. So, there are lots of great questions that have come in, and this conversation go on for much longer than this, but I am going to turn it back over to Emily Eberly to wrap things up. And we thank everyone for joining us and hope that you can take some of what you learned today back to your patients and families.
Wow, that was a wonderful presentation, and we had so many questions. I'm sorry we couldn't get to them all. I'd like to thank you very much for your time, both Dr. Auchi and as well to you, Andrew, for being our moderator today. It's been such a pleasure working with you both. And I'd like to thank each and every one of you, our guests in the live audience today, and as well those of you in a future time who are attending this recorded session. We thank you for your time and your thoughtful attention. And now this does conclude our session for today. Take care, everyone, and bye for now. We'll see you again next time.